use it? Or?
Okay, I just have this mic, right? And no hand mic.
No. Okay. Good afternoon, everyone. I am pleased to introduce you Dr. Sheetal Brar, that talks us about the Brar Safety Net, a new rescue device for PCR management during Phaco certification. Good afternoon.
Thank you, Dr. Rosa, for introducing me. Good afternoon, dear friends. So today I'll be talking about a new rescue device that we have invented in our hospital, which is Netradhama Super Speciality Eye Hospital, situated in Bangalore, India. And basically the idea behind this invention was to prevent the drop of the nucleus or nucleus fragments during the course of a posterior capsular rupture if it happens during phaco emulsification. So myself and Dr. Sri Ganesh are the co-inventors, and we do not have any relevant financial disclosures to make. So I think out of all the complications of phaco emulsification, posterior capsular rupture or PCR is one of the most dreaded complications. And why I think it is the most dreaded complication is because it starts a cascade of many more complications, right? So when you have PCR, you also have vitreous loss, which accompanies the PCR. And because of the rupture, you also have a very high risk of descent or dropping of the nucleus or the fragments into the vitreous cavity, which would certainly need a retinal intervention. And when you do a retinal intervention, you also risk the eye for different collateral damage in the form of CME, uveitis, secondary glaucoma. Also you can have challenges with IOL placement. And because of all this complicated course, the patient can have a delayed visual rehabilitation, and this increases the cost of the overall treatment as well if the patient has to undergo a retinal intervention. Now, depending upon the stage and type of cataract surgery, the management of PCR is different. So if you are doing an ECCE procedure or a small incision cataract surgery, I think it's relatively easy to manage the PCR because you already have a big wound and you can just remove the fragments through the big wound using a vectis or a similar kind of an instrument. But when you have PCR during phaco emulsification, you have a small wound and you need to manage the PCR through a small wound. That becomes a challenge. Okay, so this was the idea behind this innovation. So in a study, basically this was a 5-year audit of cataract surgery outcomes after PCR and the risk factors affecting visual acuity. This study was done in Singapore National Eye Center, and they found that the incidence of intraoperative PCR was significantly higher for surgeons in training compared to experienced surgeons. So when we talk about the current management protocols, during phaco, so there are essentially 3 strategies that you can adapt to. One strategy is abandoning the clear corneal incision and making a scleral tunnel, basically converting phaco into a small incision cataract surgery and removing the pieces through a scleral tunnel. The second strategy could be extension of the clear corneal wound itself, and of course this is going to require suturing at the end of the case, and this suturing will, increasing the wound size and suturing will lead to increased astigmatism. It can also increase the risk of infections as well as delayed healing. When you want to manage PCR during phaco through a small incision, what essentially you will have to do is basically elevate the nuclear fragments above the iris plane, followed by careful emulsification of the fragments using low fluidic parameters, and also you will have to manage the vitreous loss with the anterior vitrectomy. So this becomes quite challenging. Now to prevent nucleus drop in cataract surgery, this instrument called the Sheets Glide was introduced, and this was basically a polypropylene sheet which was 5 into 35 millimeter long sheet. Basically, you had to implant this sheet under the fragments through a scleral tunnel. You can see that the size of the wound is quite big. So also you could not fixate this device. So when you're doing Phaco, there was a higher risk of dislocating the device itself. So due to this, many people and many surgeons are not using this instrument as a rescue technique. Now, you also have a very popular technique to prevent nucleus drop during Phaco, which is called the IOL scaffold technique, introduced by Dr. Amar Agrawal from India. Now, it's a great technique. However, there are certain limitations to this technique. First limitation is that it potentially makes the vitrectomy and cortical aspiration challenging. So you have the pieces in the anterior chamber, and then you put the lens, a 3-piece lens under it, right? After implanting the lens, after introducing the lens, you will have to do the vitrectomy and cortical aspiration. So during this time, sometimes your pupil would have come down, the visibility would have been not so great. So in that complex situation, you will have to do the vitrectomy and cortical aspiration, which can become challenging. Other thing about this technique is that you will have to basically keep maneuvering the haptic all the time, because when you are doing Phaco of the fragments above the IOL, you will have to keep shifting the lens, okay, so that the lens optic covers the pupil, right? Because the optic of the lens is just 5 millimeters. So if your pupil is dilated, there will be sometimes a space between the lens and the pupil border through which the fragments can still drop. So you will have to keep maneuvering the lens so that there is no gap, right? That again needs some amount of expertise, and beginner surgeons, it may not be easy for them to use this technique. Also, visualization of the haptics under the fragments can be difficult. So if you want to do a glued fixation in that situation, you already put a 3-piece lens, you want to do a glued fixation of the haptics, but because you already have fragments there, it may not be very easy for you to visualize the haptics for the fixation. And also there can be a potential risk for the haptics to get damaged, because you are maneuvering the haptics also for the fixation. So, and the visibility is poor, you might also potentially damage the haptics. So these were the limitations of the IOL scaffold technique. So to overcome these limitations, we have come up with this new temporary rescue device, which is called the safety net device. And this essentially is a implantable, biocompatible, foldable hydrophilic acrylic material device. It's circular in shape and its overall diameter is 7.5 millimeters. So we first made the version 1 of this instrument. It was basically like a net-like structure. I think we can move a little. Net-like structure with square-shaped holes. So you can see the holes, they were square-shaped. And the size of each hole was 0.8 into 0.8 mm. So we used this in a couple of cases, and then we realized that probably we could make the holes even smaller, because sometimes very small fragments can still go through these squares, and they can still go in the vitreous cavity. So in the version 2 we did slight modifications. So we have given 4 circular holes here. The size of each circular hole is 1 millimeter, and we have given smaller circular holes inside that fill up the whole device. Now the size of each small circular hole is 0.4 mm, 0.45 mm. So instead of a 0.8 mm square net structure, now we have 0.45 millimeters circular holes. So the size of the hole is smaller, so this basically reduces the risk of smaller fragments going into the vitreous cavity through the holes. Okay. Now just showing you some cases where I've used this instrument. So you can see that I had a PCR in this case, and this was a grade 3 cataract. You can see almost 50% or less of the nucleus is still remaining. So we bring the pieces above the iris level and do a minimal vitrectomy. If you see there is some vitreous prolapsing, it is better to do vitrectomy first. Then you load the device into a 2.8 millimeter regular injector. So you don't need any special injector to load this device. You can just use it through regular 2.8 injector, and then you use a dialer to fix the device, basically to position the device under the pieces. And now before starting your phaco, you need to fix the device, you need to secure the device with at least 3 hooks. Okay, you can use 4 hooks also, but in my practical experience I have found that 3 hooks are fine, because on the 4th side your fragments would support the device. Okay, so now all the 3 hooks are in place, and now this device is actually behaving like a nice scaffold, and you can easily emulsify the fragments, of course using low phaco parameters. You know, your energy has to be low, your AFR, your vacuum has to be low, and you need to use a lot of OVD to protect the endothelium, because we are little closer to the endothelium here, and this cataract is also quite dense. But you can see that it was quite easy to prevent a nucleus drop here with the use of this device. And it's very easy to explant this device as well. You just remove the hooks and just pull it out with a regular forceps. And once you have managed the pieces, now it is very easy to do the vitrectomy, right? You can see the pupil is already mid-dilated, but you can do a good vitrectomy, look at the available capsular support, and then plan your lens. Okay, so that's the advantage. This is the video showing the use of version 2. Okay, so here you can see that I have a fragment. So I brought the fragment above the iris plane, and I'm using the version 2, and I'm using the hook. Basically it's the regular dialer to position the device on the iris. So through the 4 big holes, you can use 3 of the holes to secure the device with 3 iris hooks. Okay, and since this cataract was a softer grade of cataract, it was easy to basically emulsify the fragment, and you can see the explantation is quite easy. Okay, so one big advantage which I feel that this device can give you is you can evaluate the case with better confidence, right? So once you have managed your fragments, you've emulsified the fragments, you've prevented the nucleus drop, the next step is to implant the lens. Okay, you can assess the situation better, looking at the pupil size, if there is any associated complications such as any descemet membrane detachment or any kind of iris damage, that can be assessed. You can do a proper vitrectomy and cleanup. Also, you can look at the available support and the status of your capsular rhexis. Many times in these complicated cases, sometimes when the pupil comes down, you are not very sure if your capsular rhexis is intact or not. And if you want to place a 3-piece lens on a rhexis which is already torn, that itself will be a risk factor for IOL drop, or it will lead to a decentered or a tilted lens in the post-op period, right? You can do a sulcus fixation of the 3-piece lens. You can do also a scleral fixation of 3-piece lens using a Yamane or a glued IOL technique. So whichever technique you are comfortable with, you can use the technique for secondary IOL. Many of the surgeons do not do a scleral fixation. So for them, those who do a retrofixated IOL or a RF IOL, even for them it is a good technique to use. This instrument helps you because you can control the wound size better, right? You can manage your fragments and do the vitrectomy through a smaller wound size. So you may ask me, if I have to implant a retrofixated IOL, I might as well increase the size of the corneal wound, remove the pieces, and do a retrofixated IOL, right? Because even to put a retrofixated IOL, you will have to increase the size little bit afterwards. But I feel that there is an advantage of using this instrument first, because it's always better to maintain a closed chamber when you're doing vitrectomy, right? If you already increase the size of the wound, you made it large, there is higher risk of vitreous prolapse, right? So it will be difficult to manage the vitreous and managing the case. So that will lead to more risk of CME, increased IOP, all those problems. So this is why I feel even if you're using a retrofixated lens, you manage the complication through a small incision and then increase the size just to accommodate the lens, okay? That makes it better. Okay. Okay, so what are the indications when you should use this device and when you should not use this device, okay? So any situation in Phaco wherein you have a potential risk of nucleus or fragment drop, you can use a PCR occurring during Phaco fragmentation, preferably at a later stage, okay? So if you have a PCR when you have basically identified it in the early stage, you have the whole of the nucleus. So when you have a large part of the nucleus, implanting the device under a big nucleus can become a bit challenging, right? So if you have more than 1/4 of the nucleus is already emulsified and less than 3/4 of nucleus is remaining, you can use this device easily because you need some room to implant the device, okay? If it's already full with the nucleus, it's going to be a little difficult, okay? You can also use this device in cases where you have gross zonular dialysis due to any reason, weak zonules or intraoperative zonular dialysis, where you think the bag is not salvageable, where you cannot basically salvage the bag. In those cases, it is you can also use this device, because even in a gross zonular dialysis, there is always a risk of fragments dropping, okay? Also, nucleus drop cases where there is no access to fragmentome. So I feel it is also very useful for retinal surgeons. So retinal surgeons manage most of the drop cases. Now, if you refer the case to a retina colleague and he does not have a fragmentome, in these cases also you can bring the piece to the iris plane, and basically if you secure the device, okay, and you bring the piece onto the device, and it helps in the easy retrieval of the fragment. So I think this also can be a potential indication, you know, for retina surgeries. What you must do before using this device is that you should be familiar with the use of iris hooks. Now, we are working on this. Basically, we are trying to make a model which does not require the need of putting the iris hooks. That's going to make it much more simpler to implant, and it will be easy for those surgeons who are not used to using iris hooks. But however, for these versions, it's better if you are familiar with the use of iris hooks and you have good ambidextrity. Also, as I said, you must secure it at least 3 points. Now, you can also use 2 points fixation, but I feel it's still not very good because it's a very soft device, right? It's a very thin device. So if you just secure it at 2 points, then the edge will be, you know, kind of lifted. It will not be so well secured. You want the edge to be flat. You want the device to be flat, okay, before you start your Phaco. And also there might be a gap, so you don't want that. So secure it at minimum 3 points. And very important to do vitrectomy before insertion of the device. If you see there is vitreous, please do vitrectomy first. If there is no vitreous, then you can directly go ahead and implant. Okay. Why it's going the other way? Contraindications. Where you should not use this device. What are the cautions? As I said, if whole of the nucleus or 3/4 of the nucleus is present and there is no or limited space to insert the device, I think it's not a good idea to use the device. In that case, you might as well increase the incision and then remove it your own way. if the nuclear fragment is extremely dense and brown, okay? Like I used this case in the first case, the device, it was a grade 3 cataract, it was still okay. But suppose if it's like a black cataract and there's a lot of nuclear material there, so you might risk the endothelium. So maybe in those cases also it may be a good idea to extend the wound and remove it. If the nuclear fragment is already descending, okay, if the nuclear fragment is already, you see it's lying in the midvitreous, it is beyond retrieval, it doesn't make any sense to use the device because it's already gone beyond your reach, right? So please do not use this device when you already see that the fragment is dropping. If the pre-op endothelial count is less, right? If the patient's pre-op endothelial count is anything less than 2000, again, because we are doing phaco closer to the endothelium, it may not be a good idea to use this device and do phaco. If the pupil is very widely dilated, sometimes you have traumatic cataracts. Now in traumatic cataracts, sometimes you can have very, very widely dilated pupil. Now the size of this device is 7.5, huh? Yeah. So basically, sometimes it may not cover the full pupil, right? You want the pupil to be fully covered before you use the device. So in those cases also, it may not be ideal. If there is a damage to the iris sphincter or associated iridodialysis. Now in these complex cases, sometimes you can have a dialysis. You can have a damage to the iris sphincter. In those cases also, because you need to support the device on the iris, remember. Now if your iris is already damaged, there's no point. It's not going to basically hold the device properly. Also, if there is a poor visibility, if the cornea is already quite edematous, there are scars, there is blood in the anterior chamber, it might become challenging to implant the device in those situations, okay? So basically, we are currently doing a prospective exploratory feasibility study to evaluate the feasibility and safety of the new device for use during PCR at various stages of phacoemulsification. And what we want to assess in this study is that does this device prevent a nucleus drop? Also, does it allow us to do a proper vitrectomy and cortical removal? And does it also help us to do a successful secondary IOL implantation in the same sitting, okay? Because that's what we want to do. That's how we want to manage the case. We want to manage the case by doing a proper vitrectomy, we want to prevent the drop, and we also want to implant the lens in the same sitting. So during the study period, this includes data from our private hospital as well as our training hospital, the charitable hospital where our trainees operate. So we had 24 eyes which had intraoperative PCR during phaco with fragments. The mean age of the patients was 68 years. 5 eyes had PCR in the private setup and 19 eyes had PCR in the camp setup, okay? So that's the data. And the cataract grade of 20 eyes was from 1 to 2, and for 4 eyes it was grade 3 to 4. 6 eyes had PCR at late stage of phaco and 18 eyes had PCR at the early stage of phaco. Now basically what we found was that in all the 24 eyes, we could prevent a nucleus or a fragment drop successfully, okay? So none of the eyes had any drop, and we were also able to do an effective anterior vitrectomy with a complete cortical cleanup. We were also able to implant a secondary IOL in the same sitting. 5 eyes received a 3-piece IOL in sulcus and 20 eyes received iris retrofixation. We were able to rehabilitate the patient visually in the same sitting. We did not find any device-related complications. Neither there were any post-operative retained fragments or cystoid macular edema, retinal detachment, or any angle-related complications that occurred in any of these cases. So I feel the device has certain potential advantages. Basically, you can manage the PCR without extending the clear corneal wound, which I feel is the biggest advantage. So you are minimizing the wound-related complications by using this. You can do a thorough anterior vitrectomy and cortical cleanup while minimizing the vitreous loss. IOL can be planned after proper assessment of the situation, looking at the available support and the collateral damage. Also, since it is made of a hydrophilic material, it's very flexible, very easy to use, easy to load, easy to maneuver inside the eye, easy to explant. So it's not a very difficult tool to use. Okay, and it is simple, easy to load, easy to explant using a regular 2.8 or 2.2 injector. So it's quite user friendly. You don't need any additional special injector or additional tools. With your regular available tools in your OR itself, you can manage a complicated situation and you can use this device to your advantage. So to conclude, the safety net device is maybe a useful tool to prevent nucleus drop and its complications due to PCR during Phaco. It is relatively safe, simple, easy to use rescue device. It's a temporary device, okay? So no device-related complications so far have been noticed, and timely and judicious use of this device may prevent devastating complications and also prevent your patient from undergoing a much more major retina procedure. However, we still want to further evaluate the device and its utility in various complex scenarios, and we are still working on developing a new version of the device which is even more easy to use, it's more user friendly, that obviates the use of iris hooks, because I think that's one little limiting factor for those surgeons who are not very used to using the iris hook. So they might find it little challenging because of the use of iris hooks. So the next version will probably be a better version. We are working on it, and this will make the use of this device even more easy and convenient for you. Thank you so much.
Thank you very much. Congratulations. Any questions?
Okay.
Are there any questions?
Run again the videos because we missed the part.
Yeah, the
You
video.
want to see
The
the videos?
video.
Yeah. We'll show the videos. Can you please
Can you
play
show the video?
You can come here, sir. You can come in the front.
Just give the mic to the person who talks.
Yeah, we can. So once you have the PCR, you bring the pieces onto the iris, okay, and then you implant the device on the pupil. Okay. And once you place the device on the pupil, then you need to secure it at minimum 3 points, 3 fixation points. So we've given 4 holes, 4 big holes, and rest are the smaller holes. It's like a mesh, it's like a net. Okay, so put it at 3 points, so secure it at 3 points, and once it is secure, then you can complete your Phaco. Removing the device is also much easy.
Just to avoid the nuclear fragments.
Yeah, from dropping.
But the cortex is beneath that.
Yeah, so
Below.
once you remove this, then you can manage the cortex, you can also manage the vitreous. It becomes easy.
You do the vitrectomy
Yeah. So if
before
there is-
this case?
Yeah.
The
If there is vitreous already present, can you show the previous video? Okay, I show you another video. So here in this case also there was a PCR. You bring the pieces up, and you can actually see that there is some vitreous. Okay, there is some vitreous coming from the wound. So if you actually see, you can use a triamcinolone. You can see that vitreous strand was there. So in these cases, it is better to do vitrectomy first. Always do a vitrectomy if you feel that there is vitreous. So clear the anterior chamber, make space, and then you can implant the device. This was version 1 where the holes were bigger. Now we have a version with smaller holes.
And
Okay.
you lay it on the iris, not
On the iris.
under the iris, on the
Under the fragments and above the iris. So it acts like a scaffold. Okay. So it's a temporary rescue device. It just does its job. Basically, it prevents the nucleus drop. So you secure it on the third side. Okay. Yeah, and then put loads of OVD.
Right, this is better than the glides.
Better than the glide, yes, but much better than the glide, because in the glide it's like a sheet and it's not secure. You have to put it through a big incision. Here you just use it through a 2.2 or 2.8 incision, and you can do the Phaco. Of course, you need more OVD. Keep putting the OVD to protect the endothelium. This is a little denser cataract. Okay. See, now it's done its job. The job of the device is over. You just remove it using a regular forceps. And now if you have any vitreous, you can manage the vitreous. You can manage the vitreous, you can manage the cortex. And looking at the capsular support, you can put the lens of your choice. You know, you're comfortable in a 3-piece or a retrofixation.
Nice.
What do you think about this?
Yeah.
Huh?
It's a clever device.
Clever device.
And of course, you cannot use it in all cases.
Yeah, I told you the situations where it would be safe to use this.
If in the beginning, if the nucleus starts to tilt,
Yeah,
and,
that's what. If you already see that it is tilting, it is in the mid-vitreous, then it cannot help. Basically, it can prevent a drop in the early stage of the Phaco, of the PCR.
Is this available?
This will be available in some time, because we are working on a third version, where you will not have to do the hooks. There won't be any use of the hooks. Okay, so that will make it much
How
more
will you
easy
do
and
that?
faster.
How will you do that?
How will it? Yeah, we will do it. We have a strategy, but it is going to make the use much more easy. Just go, pull it, secure it.
It's acrylic.
Acrylic, hydrophilic.
Hydrophilic.
Yeah. Because I've been training lots of surgeons, doctors, trainee doctors, and they have lots of complications. I was always thinking, why cannot we make something that prevents the drop? Because when the patient has to be sent for a retina surgery, right, it's a lot of extra discomfort for the patient, extra cost.
But they have to be trained also to do a proper vitrectomy without losing the fragments in the vitreous.
Yeah, I mean, vitrectomy, you don't need a pars plana vitrectomy here. You can just go through the main port or the side ports. Just remove the vitreous. That's why you have to act early. So in the beginning phase itself, when you see the PCR and you see the fragments, you decide to use the ring, the device. If you manipulate too much, your pieces are already going, then no point.
Yeah.
So early recognition is the key. You recognize the PCR in the early stage.
You have to bring them up.
And bring the pieces above and then implant it. It's quite easy.
Clever. You designed that?
Yeah.
Congratulations.
Thank you.
Thank you.
Thank you.
Please spread the word about this. If you meet your other colleagues, they can also come. They can see the videos.
Can I have a brochure or anything that?
Brochure is not ready right now.